Okay, sinus dysrhythmias. There are two evil stepsisters of normal sinus rhythm. We have sinus tachycardia and sinus bradycardia. They're evil sisters because they're otherwise normal except for the rate. That is the only thing wrong with sinus tachycardia and sinus bradycardia. In sinus tach, obviously the rate is over 100. And in sinus brady, the rate just happens to be below 60. So questions, like I said, what are the questions I'll be asking on the test? What are the four things?
What it looks like.
What does it look like?
What it looks like. This is what it look like. What else?
What causes it?
How you treat it?
Okay, what do you do about it? And then finally,
Signs and symptoms.
Patient teaching.
Patient teaching. Like I said, signs and symptoms, they all look the same, right? I mean, they all have the same symptoms because we already looked at it, effects of bradydysrhythmias, effects of tachydysrhythmias. You remember that part? Because they really share the similar signs and symptoms, except for the part where it says palpitations, because you see palpitations in sinus brady or in any brady dysrhythmias, like heart blocks, for instance, are all brady dysrhythmias, so you won't see them with palpitations. All right, and then that's basically what you read. So let's start with sinus tach. These are the known causes. So therefore, if either the treatment or your interventions will either be simply monitoring the patient or treating or assessing and treating the cause. So you assess for these. These are the causes of sinus tachycardia. Then if you can control them, then do so. But your first action is always what? What was one principle we learned earlier under chart 34 dash, what is this? Dash 2. Evaluate the patient's response to dysrhythmia. How is the patient tolerating it? So therefore, your next action, whether or not to treat it, depends on the patient's response. And how do you monitor patient's response? What does this actually mean? This one, the third bullet. What is this response that the patient is, that you're supposed to assess in a patient? How do you know how a patient is responding to a dysrhythmia?
They might have anxiety or restlessness.
Well, those are the causes. This one. What would be, how would you know? Let's say I'm having a dysrhythmia right now. How would you know how I'm handling it? I'm in my room right now. So Michael, you come in, assess me. So how do you know how I'm responding to the dysrhythmia that's on the monitor?
You might be like shocked, or you might be just still, maybe holding your chest or something.
Is that enough? You look like the patient looks like Mr. Scarda looks like he's scared. He looks startled eyes. He looks scared. He's, you know, he doesn't look very well if he's scared. So how do you know how I'm responding to the dysrhythmia? Come on, basic thing. So how do you know?
Breathing.
You would see a vital sign change or maybe the rhythm change.
Vital signs. So you check my vital signs, right? How is my blood pressure? Because that's, you're really trying to evaluate how is this dysrhythmia affecting my cardiac output? Because that's the main thing about chapter 34, is how are dysrhythmias, because this is care of a patient experiencing dysrhythmia. So therefore you see how is the dysrhythmia affecting your patient. First action is always the vital signs. Is it, how bad is the decrease in cardiac output based on each dysrhythmia? All right, so don't go looking for grabbing a beta blocker right away. So when you see a patient in sinus tach, don't go to the Pyxis and getting a beta blocker, right? So therefore, your first action is assess the patient first. How is the patient? Your next decision with your treatment will depend on how bad is the response. If the response is the patient's going into shock already, then they definitely need drug therapy. But if the cause is anxiety, for instance, are you going to beta blocker my ass if I'm anxious?
No.
No. Okay, so you address it depending on the patient's response. Okay? 'Cause, of course, realizing that these responses are normal to these factors here. So if I'm anxious, yes, my heart rate will go up. If I'm in pain, yes, my heart rate goes up. If I'm under stress, if I have fever, etc. Maybe I'm dehydrated, right? Maybe I'm not drinking enough. So that would also, maybe if I'm bleeding, okay? Depends really on the cause. So you assess the patient first and then try to identify and eliminate the cause if possible. So my suggestion is, of course, read the whole paragraph because you have more than one possible cause there, and they have actually suggestions here on what to do. All right. Here's an action alert. So of course, this one, that means the sinus tachycardia either has been prolonged or maybe the heart rate is really extremely fast or extremely high rather. And obviously the patient now has decreased perfusion. See, patient already has oliguria. So that means this is now serious. A patient definitely is symptomatic and does require treatment. What about sinus Brady? And here are your teachings. Okay, so teachings for the patient as well as teaching when you do give pharmacologic interventions. Then of course you monitor for side effects of those or if there are any applicable patient teaching as well. Let's go to bradycardia now. So these are the known causes. We have carotid sinus massage, which is a intervention for ventricular dysrhythmias. We'll talk about these later. Vomiting also causes sinus brady. So the same as suctioning, vomiting, same thing. You're either vomiting yourself or the nurse is having you, sucking it out instead of you vomiting. Giving birth to a big turd can also cause bradycardia and MIs, right? Or effects of these medications, just like right here in sinus tach. So it can also be caused by medication administration, right? And as you can see, they don't have under interventions doesn't really mean you treat right away, right? Here are the possible manifestations. So therefore, if the patient is asymptomatic, does it require treatment?
No.
No. Remember I said, like ripped guys like me with, really good, athletic guys like myself, we have normally low heart rates. Okay, so if we don't have any symptoms, then that means we're fine with it. Here, if the patient is stable, treatment includes identification and treatment of the underlying cause. So you simply identify these guys right here. Not all of them though we can eliminate because let's say the patient's on medications. So if they need that medication, maybe just the dose might be changed. You just communicate it to the doctor. No, his heart rate's been 42. No, he's on this. What do you want me to do? All right. Please do the details here. Clearly says if the bradycardia is caused by beta blocker overdose, you can give glucagon. Glucagon is an emergency hormone, right, which increases heart rate. This is given in hypoglycemia, symptomatic hypoglycemia. Some patients, especially if we're talking about heart blocks, will require pacing. Permanent, depending on the cause, the doctor decides whether the patient will require temporary versus permanent pacemaking. In the case of second degree type 2 and third degree heart blocks, those definitely need permanent pacemakers. If the patient, if this is an isolated event, meaning not likely to reoccur, the patient may simply be put on a temporary pacemaker. Just like what happened after coronary artery bypass grafting, Cabbage, last week. So part of the post-op care is one of the tubes coming out are pacemaker wires along with the mediastinal chest tubes. All right. So there are two pacemakers mentioned here. We have temporary and permanent. The teaching will be toward the end of the chapter. So there are two ways here for temporary pacemaker. You simply do a transcutaneous. These are like pads, just like an AED. So you slap the pads on the patient, peel off the adhesive, put them on, attach them to a handheld temporary pacemaker, and then voila. And transvenous is done by a doctor now, still attached to an external pacemaker, but this one now, the wires are now put into the heart instead of just the pads. Pacemaker insertion, like this one, permanent pacemaker insertion, is not an emergency procedure. This one can be scheduled because we have the temporary ones. Okay, these are effective. Okay, transcutaneous or transvenous are effective. Between the two, transvenous, of course, is more effective. But this one, the procedure isn't really an emergency. We can do this tomorrow, okay? Meaning if this happens in the middle of the night, the doctor doesn't have to come in and perform the surgery. So we can do a temporary, and then they'll come in the morning and then put that in.
Hey, Mama, when do we go?
Yes. Okay, maybe class, thank you.
So, Professor, transcutaneous and transvenous, these two are not these two are non-invasive, right?
And well, the transcutaneous are only pads. It's like an AED. You put on pads on the patient and attach it to a external pacemaker. The transvenous is still a temporary pacemaker, but then the doctor puts in wires into the patient's heart. But this is again temporary though.
Okay.
Meaning the wires are coming in from the skin, unlike this one, where the whole thing, the whole operation is inside the patient now. This is now in the subcutaneous tissue. And they put the wires through the subclavian, and that ends here. Okay, this is now a permanent one. It's in there forever.
Oh, okay. Thank you.
Unless, of course, they get infected, because that does happen.
Yeah.
And they'll be taken out.
Okay. Thank you.
Okay. So here's a little action alert, but this will be mentioned again in the big chart toward the end of the chapter. You can read this, but I'm sure these are also found in the big teaching chart. Never mind, it's right here. I thought it was further later. I remember the ICD is found later. Sorry. So here is chart 34-3. So these guys here in the action alert are already here in chart 34-3. And just read, and it's a good, very good select all apply question. Please take note about the microwave, because we still have, and it can be deceiving or may confuse you, because we still have signs in city hospitals. Because I mean, how old are our city hospitals? They're over 100, right? Look at Bellevue, for instance. How old is Bellevue? 100 what?
It's
150 years old, I think.
Yeah.
So those signs there, they may have missed them. We still have signs in some units that say, you know, microwave in use. If you have a pacemaker, don't operate this. That's old, okay? Modern microwave ovens are safe to operate, but I'm only saying modern, okay? So if there is a 1970 microwave oven somewhere, let's say when you're taking a trip and you stop by gas stations out of nowhere, they may still have those old microwave ovens there. Those the dial ones instead of the digital.
Yeah.
I don't know. I can't say the same for those. Okay, and those are really old microwave ovens. I don't know how they'll affect your pacemaker, but I'm talking about digital modern microwave ovens. Okay, they're safe to use. All right, let's start with, so we're done with sinus dysrhythmias. Pacemaker if needed. All right, let's do atrial now. Begins with PAC. So there are three. We have PAC, SVT, and atrial fibrillation. The fourth one is atrial flutter, which is pretty much the same as atrial fibrillation. PACs, I showed you a picture earlier. So these are generally harmless. They don't cause any effect on cardiac output at all, although it will scare the patient. Because like I said earlier, what follows it? What follows the PAC? A
PAC is
Pause.
pause. Okay, there's always a pause. So the patient literally feels like, oh, I felt like my heart skipped a beat. So for those drinking coffee and you felt this at one point, you may have experienced a PAC, which again, you're still alive now, so that means it's harmless. In a patient with cardiac disease, though, it's now a big deal because this could be just a warning that you have a dysrhythmia now. You may have another later, which may be more serious than the one you just experienced. These are the typical causes. So we get these all the time, stress. So during exams, you may have a PAC also. Or when you don't get enough sleep, you only slept 1-2 hours for the past 7 days. Yeah, so you have fatigue, so you'll have PACs as well. You can read the rest. Is coffee there? Yeah, there you go. Coffee and smoking. Right there. So let's count that the first one. Okay, so strike one for these three guys here. As already mentioned, they typically have no symptoms except for the palpitation and the, of course, needing to skip a beat. Only if they occur more frequently now, so that's different now. Right? The patient now will become symptomatic and therefore will require treatment. But otherwise, you just avoid caffeine, alcohol, and nicotine, because it includes also chewing tobacco, not just smoking. All right, we're interrupted by the drugs here. This is how your author presented it. The best textbook I've seen for dysrhythmias is the one from Davis, the one I showed you earlier, where the heart blocks are, or where the PAC was, I think, whatever textbook that was. That was the best arrangement. I'm just saying arrangement because they put the dysrhythmia, the picture right there. They give you the strip, they give you the causes, they give you interventions, they give you the teaching, and then move on to the next one. So that was a perfect one. So this one, it's, well, you have the pictures together with these, but then the intervention, the drug therapy is in one chart. Chart 4-4 contains all of them. So here, you need to find them though. I highlighted them for you. Okay, so you can begin here. So for class 1, I'm testing lidocaine. And here are your nursing responsibilities. Next one, for class 2, you have the olols, propranolol, acebitol, esmolol, solol. All right. Can I move now?
Yes.
Okay. Watch for these, okay? You should know this already from third semester as well as in, yeah, twice in the third semester in pharmacology in 104. Okay, this is a continuation. You have solo. And next are amiodarone, dronedarone. You finished. Next are verapamil. So these are your DHP calcium channel blockers. The non-DHP ones, if you remember, they end in dipene. You have nicardipine, amlodipine, belodipine, right? Those are only used for hypertension. These are the only two you use for dysrhythmias. All right, because these are the DHP. If you don't remember DHP from pharm, these are the two that will affect cardiac cells, whereas the non-DHP ones only affect blood vessels. Does that make sense? Meaning they're calcium channel blockers, but the non-DHPs only affect the calcium channels on the blood vessels, on the arteries. These DHP ones, these two, affect the cardiac cells as well. So not only the vessels, not only the calcium channels in the blood vessels, but also the cardiac cells themselves. And then others, digoxin, atropine, adenosine, and that's the end of the chart. Got it? Yes, you
Yeah,
finished?
we got it.
Yes.
Yes.
The next one from PAC is SBT now. So this is different from the VTAC. Okay, this one is still ventricular tachycardia, but this one, the cause is from the atria. So this is different from a ventricular tachycardia, which is more serious. This one, I'm not saying it's not serious. It's still serious, but just that the cause is above the ventricles. So the cause here, the culprit came from the atria. So SBT, I don't think there's a strip for this one. I won't test you on the strip because there's no strip. Let me just show you what it looks like if you do see one. Okay. What does this remind you of? What does this look like? Okay, this is not SBT. This is actually sinus tack. But look at sinus tack and look at where's my SBT. Sinus tack. SBT is, that's Atrial Flutter. Look at, no, that's Flutter, right here. Look at this and then look at your picture for sinus tact. They're identical, right? The only thing missing here is this one here has no P wave. So if you look at something that has a high heart rate like this, but then no visible P waves, then that's now SBT.
No P.
Right, that's the only difference here. If you compare this side by side with a sinus tachycardia, they almost look the same. The only missing is there are no P waves. Here you can see SBTs. I mean, you can see T waves, sorry. So in an SBT, there are no visible P waves. Right? Because the heart rate here is already in the 200s to 300, so it's so fast. It maybe, I don't know, varies the P waves, I guess. All right, causes of SVT. Right here. Oh, I forgot to mention. Here. Now, take note that this is under atrial dysrhythmias, right? So therefore, since these three are atrial dysrhythmias, that means they can be caused by these because they are all sinus dysrhythmias. So on top of this caused by PAC, these can also cause SVT. Does that make sense?
Yeah.
Because they are both atrial dysrhythmias. Because it's not mentioned here. All right, here are your signs and symptoms. As stated here, it depends on the SVT because SVT can be paroxysmal. Where is it? Paroxysmal meaning it's not mentioned here. Anyway, in paroxysmal, oh, right here. So SVT can be sustained or paroxysmal. Sustained is the picture I showed you earlier. It looks like sinus tach with a missing P waves. Okay, so that's sustained SVT. It can be paroxysmal, meaning it only occurs in spurts. Let's say the underlying rhythm is either sinus rhythm or sinus tach. So you'll see a rhythm that has a PQRST, 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 but then you'll see a series for probably several seconds wherein you'll see SVT. You'll see SVT. So if the pattern is like that, meaning it occurs in spurts. Let's say you're watching the patient's monitor, they were fine 1 minute, then a few seconds later they go into SVT, but then it resolves on its own. It stops without intervention and then returns back to baseline, back to the patient's underlying rhythm. And then moments later it returns again. If it's that pattern, then it's called paroxysmal SVT. So again, it's either sustained, meaning it's the basic rhythm, or it could be paroxysmal, wherein you have a different underlying rhythm, and then the event occurs only in spurts. This is one of the interventions. So otherwise, in PSVT, if it stops on its own, then no intervention necessary. If it continues, then the patient goes to the cath lab to get a EPS done. EPS study is a mapping, meaning it's in the cath lab, it's a department, there's a room in the cath lab wherein they put you in there and they put 1,000,000 electrodes on your chest and they study also using a scan. There will be a something like looks like an x-ray above you wherein they'll take pictures of your heart to see where are these signals coming from, what's causing these these signals that are causing it. So if they find them, then they'll go in and burn them. So this is the next procedure that will be done because they have to destroy those sources. Meaning once identified that, oh, these are the ones firing these signals causing the patient's SVT. So the patient will now undergo radiofrequency catheter ablation. So you're already in the cath lab, so they'll go in, you'll have a cath lab cardiac catheterization, but instead of putting stents in your heart, they'll be burning the catheter. Is going to burn those identified sources, okay? So this is done also for SVT, as well as AFib, A-flutter. Other interventions for SVT is vagal maneuvers. What we do today is they'll give you a straw and they'll have you breathe through a straw, or blow through a straw, because that simulates, you know, you're having a Valsalva maneuver um, without actually pushing something out. So you just, the doctor gives you a straw and tells you, okay, blow through that as long as you can. This one is another procedure, although this is dangerous. You should have emergency equipment when a doctor performs this. Anyway, he'll tell you anyway to get the crash cart ready. These are the complications. This is literally, he'll massage one carotid. So he'll massage the patient's neck. This one, the purpose is to stimulate the vagus nerve to slow down conduction. So this will of course lower your heart rate, and he doesn't know when this, you know, when exactly to stop. So these are your complications. All right, these are the complications of carotid sinus massage. So therefore, a patient may develop, in fact, this was mentioned in sinus brady, right? You remember? One of the causes of sinus bradycardia was carotid sinus massage. So here's the safety. You should have your crash cart when a doctor is performing that. Here, this is the vagal maneuver. Again, we can do this with a straw. Okay, the drug for SVT is adenosine. This drug, please read also on chart 34-4. Anyway, you have a drug alert here. So this is expected. The patient, the effect of the drug is the patient will have a short period of asystole, meaning this is done to restart the heart. So it will the patient will flatline for a few seconds, and then it should restart. Right? So that's how the drug works. The problem is, what if it doesn't come back? Okay, because occasionally that happens. So what should you have at the bedside when a doctor, or this can also be administered in the ambulance or in the ER. So what should you do when giving this drug?
Emergency equipment.
Okay, because just in case the patient stays in a systole, right? So you need emergency equipment to bring them back. So yeah, so when giving that drug, be sure you have emergency equipment. This is how you give it. It should be given really fast, over several seconds. Okay, not like when you're giving opioids, when you take your, you push it really slow, right? Over 2 to 5 minutes. This one, you literally push it hard. So it's given undiluted. You push it quick, and then you also follow it with a normal saline bolus. The bolus here is not a bag, okay? This is a push. So you push it also with 20 ml of saline, because the drug literally, the half-life is about 10 seconds. So therefore, if you take your time giving it, by the time it reaches the heart, is it still effective?
No.
No, not with a half-life of 10 seconds. So you give it fast, and then you flush it with 20 ml fast also. That way you deliver it straight to the heart within 5 seconds. All right, because otherwise it won't work, because you took your time, then the drug is gone by the time it reaches the heart. So give it fast, and then flush after it really fast also. These are other options, beta blockers or calcium channel blockers. I'll explain cardioversion shortly. So this is also, atrial dysrhythmias have similar interventions. So we saw SVT so far. We did the EPS, right? And the catheter ablation. One option is to do synchronized cardioversion as well. I'll discuss this one under AFib. Okay. Here's AFib. So the causes of AFib, look at the picture. No, no P waves. These are not P waves. They don't look like P waves. These are F waves. They are fibrillatory waves. These are your causes. Age is number one. And then anytime you have a condition wherein the pressure in your atria, particularly your atria, increases, let's say valve disorders, for instance, or if you have an MI, can also trigger AFib. Heart failure can trigger AFib. So anytime you have buildup of blood and pressure inside the heart, so when they overstretch the atria, they cause these ectopic sources to fire and causing these F waves here. So therefore, no P waves. Are the atria really contracting?
No.
No, no P waves, no atrial, no true atrial contraction. So what the atria are doing here is just quivering, okay, just having tremors. They're not really contracting. The danger here is, of course, not only decreased cardiac output, but there will be clotting here. So blood hangs around the atria and also the ventricles as a result. So therefore, increases the likelihood of blood clots. The goal of treatment here is to, right now this is good because look at the heart rate, the ventricular rate, I mean, 1, 2, 3, 4, 5, 6, 7, 8. So this is the heart rate, the ventricular heart rate is in the 80s, which is good because what if the AB node, this is another um, heroic function of the AB node is the AB node is smart enough not to respond to these electrical impulses here. Because if imagine what the heart rate will be if the AB node conducted these electrical impulses here. Because these are still electrical impulses. Look at how many of them are. 1, 2, 3, 4. Imagine if there's a QRS within after each one of these. What will be the ventricular heart rate? Meaning for every one of these electrical impulses, because these are not P waves, however, they are electrical impulses coming from, I don't know where they're from, but they're not from the SA node. So what if the AB node responded and transmitted these signals? What will happen to this heart rate? Easily get to 400, 500, right?
Increase.
Right, so therefore, this is another evidence that, oh, the AB node is doing its job. You know, the AB node didn't fall for these guys here. AB node recognized, oh, that's not coming from the SA node. No, it didn't respond to it. So as long as you have a controlled ventricular response, then the AB node is doing what it's supposed to do. So on top of your decreased cardiac output, your number one concern here is clotting. So stroke, PE, etc. Okay, so we will have clotting problems here. So these are your causes. Risk factors are the following. I mentioned already valve disease and heart failure, and well, MI leads to heart failure. So yeah. Okay, signs and symptoms, of course, related to decreased cardiac output. Those are your symptoms. However, if the patient's ventricular rate is controlled, the patient may not have any symptoms at all. AFib has different types. Paroxysmal, just like SVT, paroxysmal SVT, it comes on, comes off, comes on, comes off. It can also be persistent, meaning it's continuous. No matter what you do, they stay in AFib. And then you have permanent AFib, meaning they're likely to be in this condition forever. So of course the therapy will be for life, especially the anticoagulation, unless they respond to the invasive procedures, which we'll discuss next. But basic interventions for AFib, we always start with, please read this. I kind of already said that, so watch for clotting. Now here, traditional interventions start with medication first. So our goal is to convert the rhythm. So we give drugs in order to convert the AFib or A flutter to, because the A flutter will be the same, convert the rhythm back to sinus. So these are our drugs, diltiazem, and what was the other one? The other DHP, the verapamil. Okay. So, but the most common one used is diltiazem. So this will be in a drip. So you hang this bag continuously. So that will control your heart rate. And we can also give the patient amiodarone or jonedarone. Not and, okay, that's or. Either jonedarone or amiodarone. If the drug therapy doesn't work along with these heart rate reducing drugs, we can also give beta blockers, digoxin. If they do not work, then we can try these drugs, but I'm not testing them. Okay, we didn't highlight them on the chart 34 dashboard, so you can skip this paragraph here. Let's go now to invasive procedures. But before that, let's do anticoagulation also. So we just concluded PE, so same procedure. We do heparin first and then convert them to warfarin. And you already know the protocol. As far as NOACs or novel oral contact anticoagulants, remember what's the contraindication for these? What does the commercial say? I have AFib, a type of irregular heartbeat not caused by a. What does the commercial say? Not caused by a valve problem, right? Okay, so if it's a non-valvular AFib not caused by a valve problem, just mentioned here. Where is it? Right here. So not caused by a valve problem, then you can use the NOACs as your anticoagulant. Okay, these are applicable. They are better than warfarin, again, but they're not everybody are candidates because they have to be a non-valvular AFib. And you already know what to teach a patient with any anticoagulant. All right, so the patient didn't respond to drug therapy. We did what we can. Patient now continues to be in AFib. Doctor will try electrical cardioversion. Electrical cardioversion is the same as defibrillation, the same equipment, the same defibrillator. It's just a matter of how the defibrillator was used. So you know what a defibrillator looks like, right? Not the AED, the actual big defibrillator we see on the crash cart. Do you know what I'm talking about? Have you seen one?
No.
Okay. Do you see this?
Yes.
Okay, so this is the defibrillator. You have this on the crash cart in any hospital, in any unit. So this is a defibrillator. Now, this can be used as a synchronized cardioverter. If you turn on this, you see this sync button right here? See this button right under that red electrical bolt symbol?
That's why and see.
Yeah.
SYNC?
Mhm.
Okay. So when that button is lit, you turn that on and then the green LED is lit here next to it, it becomes a synchronized cardioverter, or simply a cardioverter. There is no asynchronized cardioverter. Okay, when we say cardioversion, we refer to synchronized cardioversion. Okay, so again, this is a defibrillator. It can be used as a cardioverter if you turn this sync button on. Are you with me so far?
Yeah.
All right, so that's the same equipment. The difference is when you use it as a defibrillator, of course, the um, the electric shock is delivered whenever the user presses the button randomly. So it's just a matter of no chance. When the doctor says, okay, deliver the shock, somebody presses the button and then the electric shock is delivered instantaneously. So that is a defibrillator. In electrical cardioversion, there is preparation here. So before we schedule this procedure, because this is non-emergent, although it can be done in the ER, we have to do a study first. We have to make sure, because the danger here is if there's a clot inside the heart, you can dislodge the clot and then the patient gets either a PE or a stroke, depending on where the clot is, which side of the heart the clot is. So therefore, before we do electrical cardioversion, we have to do an echo first. So we have to look at the patient's heart. Once we see that there are no blood clots in there, then the doctor will proceed with the procedure. So therefore, since this is synchronized, the patient, of course, is connected to the machine, just like the defibrillator. However, when you turn on the sync button, and then you press the button to deliver the electric shock, the shock won't be delivered right away. So it'll be a few seconds before the machine delivers the shock, because it will synchronize first with the patient's rhythm, meaning it will analyze the patient's rhythm and then deliver the shock at the peak of an R wave. Does that make sense? Hello?
Yeah.
Okay. So here, what we're trying to avoid is delivering the shock at the T wave, because this can cause BFib, and it's dangerous. So the objective here is to deliver the timing of the electric shock, not randomly, but precisely at the peak of an R wave, meaning at the peak of a ventricular contraction, that's where you deliver the shock. And when done that way, of course, that will restart the heart. And then usually this is very effective. Converts the patient back to sinus. Not all the time, but most of the time. However, imagine you are the patient like that. So would you like to be awake for this procedure?
No.
No.
No. A VFib patient, those patients are unconscious, right? Because that's why we call the code, because they're unconscious, no cardiac output, right? They're in fib, they're in ventricular fibrillation, so they're shocked, but they're unconscious. This one, the patient is awake. So therefore, would you like to have this procedure while you're awake?
No.
No. So you get consent. Of course, the doctor gets informed consent. You can get the signature or the patient or the family member. The patient will have to be sedated here, just for comfort, right? Because I mean, imagine me holding the paddles against you and then looking at you with a smile and saying, "Hey, Islamo, gonna do your version, okay? You ready?" So yeah, that can be scary. Plus the fact of you being awake and then being electrocuted, pretty much. So we have to sedate you, given a small dose of sedative for the procedure, and then that should make it more tolerable. But since you're using the same equipment, so you still shout clear, just like a defibrillator.
So, Professor, after giving this defibrillator at the R wave, when it reaches the R wave, ventricular contraction, so it will actually stimulate the P wave, right?
Yeah, so the patient usually converts back to sinus rhythm.
Okay.
If not, then that's what we call a permanent AFib. So
Mhm.
too bad, the patient will just be on anti-dysrhythmics for life. They'll be on anticoagulation for life.
Okay.
Okay, here are your responsibilities after the procedure. Okay, please read that. This is a option. Have you heard of Watchman commercial? No, the commercial when there was a daughter driving her dad to the hospital, and she said, "Yeah, he was just playing with Emma. Then he hit his head. He will stop bleeding. You know? Oh yeah, right. He's on AFib." And then the doctor said, "Yeah, I understand your concern, but there is an alternative." And the patient says, "Another pill?" He says, "No, it's called Watchman." Okay, so this is a device that they'll put it in this corner right here, left atrial appendage. So this is a corner of the left atrium, obviously,
Mhm.
because based on history on TEEs, when you do an echo, the clot usually forms in that corner of the left atrium.
Mhm.
So it's a natural shape of the atria wherein clots tend to accumulate. It's like a quicksand, like a dead space, you know, a corner wherein blood gets trapped in there, and that's when they form a clot. So this procedure will put this device in there, thereby eliminating that dead space.
Mhm.
Therefore, no clots will form.
Mhm.
All right, so that's an alternative. I already described radio frequency catheter ablation. So we do the EPS, and then patients undergo that cardiac catheterization to burn those pathways. Um, Pacing, we already mentioned. I'm not testing the other procedures like the maze. They will stop at catheter ablation and cardioversion. This is another teaching for no nursing responsibilities for, because most of our patients are 65 and older. It's not really different, but um, just in case the test question uh, hits a few uh, details, okay, so please read this. But like I said, they should be similar. This is dysrhythmia, so regardless of the age, it's bound to be similar, but there might be a few differences, okay, maybe one or two. Please read that chart. I don't remember a question on this PCC box. All right, we're about to discharge. No, we haven't done ventricular dysrhythmias yet, so we're not done yet. The teaching here for AFib or A-flutter is, of course, regarding medications as well as anticoagulation therapy, or if they are on, um, if they're on warfarin, then include the diet restrictions. Here's another teaching for prevention, chart 34-6. Please read them on your own. All right, there are 4 ventricular dysrhythmias. We have PVCs, VTAC, VFib, and asystole. PVCs, I showed you a few pictures earlier. They're the same shape, so that's unifocal, same source. This one, 2 different shapes. There are multifocal PVCs. Um, just like PACs, what follows a PVC? What is this?
Pause.
Right, this one. So any premature atrial or ventricular contraction is always followed by this pause. These are your causes. We did see this in the MI patient, right? In the MI patient, this may trigger or be a warning sign of a more serious dysrhythmia. Right here, here's that, what I just said. That's where that is. So it's not good to see in a patient with MI, okay? Just consider it a warning so you can monitor your patient. That just means the ventricles are very, very irritable, especially after injury. So that's why it's common after an MI. Otherwise, PVCs, you just like PACs, you monitor the effects on the patient, look for and eliminate the causes if you can. But however, if the patient's having an MI and PVCs, therefore you call the doctor regarding that. Here, if there's no underlying disease, then they just monitor, then eliminate the cause, or if you can identify the cause, then treat them individually, okay, specific to the identified cause. VTAC. There's nothing else like this. That's VTAC. No, no P waves, no QRSs. Right? There's nothing else you can compare to this. They're not always uniform like this, but any variation, let's say you get it on the NCLEX, that's VTAC. Okay, if it's like this, it may not always be very uniform, but that's still ventricular tachycardia. Look at the rate, anywhere between 140 to 180 or more. Definitely, there's no cardiac output there. However, there are two types of VTAC. VTAC can be with a pulse, or it could be a pulseless VTAC. The interventions vary. These are other causes of VTAC, including what you on again, Michael? Are you on this or something else?
No, something else.
Okay, good. Stop it, because that causes VTAC. So a VTAC can be, meaning the patient still has a pulse, therefore still has cardiac output. In that case, this is what we treat them with. We give them anti-dysrhythmics. Confirm though that there is a pulse, then you can give these. Patient with a pulseless VTAC is the same as VFib. So the term will either be unstable, or I will say pulseless VTAC. When I say stable, that means, is there a pulse?
Yes.
Yes, okay. So therefore, what's your first action when you see this on the rhythm?
Rapid response.
Well, before that, what do you do? Because remember, there's a pulseless VTAC and there's a VTAC with a pulse. So what do you do first?
Check for a pulse.
Check for a pulse. That way you can distinguish, because your next actions, remember, depend on whether or not the patient has a pulse. If it's patient has a pulse, remember, these are your treatment. If the patient is pulseless, then you start CPR. You call the code and start CPR. Patient needs defibrillation, epinephrine, atropine, and all that. Okay. ACLS is not discussed in this textbook, so that's where we'll stop. We just say patient will receive chest compressions and then ACLS. Okay. This is now VFib. Very disorganized, no pattern, nothing else like that. Just like pulseless VTAC, of course, there's no cardiac output, so we'll begin chest compressions. Okay. Until somebody grabs your AED or your defibrillator, then you apply the pads onto the patient and just follow what the machine recommends. Right? So at this point, the rapid response is already at the bedside, and the doctor will direct the orders as to which medications to give. Again, ACLS is not covered by this textbook, so we can skip that part. Last one, well, there's still syncope and ICD after this one, but we're almost done. Asystole, so no rhythm. It's a flat line. So do we defibrillate?
No.
No, because there's no rhythm. There's nothing to shock. There's nothing to convert because there is no rhythm. So all we do here is just do chest compressions. If the patient goes into fibrillation during the compressions, then that's the time you defibrillate. But no electrical impulses, therefore no rhythm, chest compressions only. And of course, this will include ACLS as well. The patient will be given epinephrine, atropine to stimulate the heart. But until you get a rhythm, continue chest compressions. All right. CPR, you should know already. So I have a question on CPR. So please, for those especially who did not actually do their CPR, but just paid for their BLS card, so please read, okay? I have questions on basic BLS, questions here on BCLS for exam 3, okay? Here are possible complications related to CPR. Just a reminder, do not stop chest compressions until the defibrillator or the AED is, the pads are applied to the patient. And then whenever it tells you, I mean, just follow what the machine says, you know, stop CPR, then you stop for rhythm analysis. And we already know this, we do not defibrillate asystole because again, there's no rhythm, this patient's not in fib, so we cannot defib. And I already mentioned this, ACLS is beyond the scope of this textbook. It's a different textbook. Okay, that's AED, you know that already. All right, let's go to ICD. So the patients here who receive an ICD are those who had one or more episodes of VTAC or VFib not caused by an MI. Again, who gets an ICD?
Sustained.
Case one, sustained VTAC or VFib not caused by an MI, okay?
Yeah.
So they were lucky enough to survive this episode. These are fatal dysrhythmias, obviously. So you had a VFib, you're still alive. You had SVT, sustained, you're still alive today. So the doctor will recommend you need an ICD, okay? ICD is implantable cardioverter defibrillator. So therefore, it's computer, of course. It will detect SVT or VTAC with a pulse, I mean, a pulseless VTAC, or even VTAC and then VFib especially. So if you develop these, it's a cardioverter. So it will, of course, the electrical shock won't be as high as those of a AED or defibrillator, but it's better than nothing, okay? But it keeps you alive at least until you reach the hospital, because your teaching here is, of course, if it fires, that means why did it fire? Mr. Kimmins, why did the thing fire? Why did we put it in? Patients who survived what? Sustained VTAC and ventricular fibrillation, right?
Right.
Right. So that means if it fires, what happened to the patient? Why did the device fire?
They went into a dysrhythmia.
Very good. They developed a VTAC or VFib. So that's why the machine, the device fired. So that's why it says here, read the rest. I'd like to point something out here. Okay. If it discharges, where is it? Most of the teaching is similar to pacemaker, so some of them are redundant. However, right here. Thank you for reading this, Miss Christina.
Professor, you want me to read it?
Yes, please.
Okay. Follow instructions on what to do if the ICD successfully discharges, after which you feel well. This may include maintaining a diary of the date, the time, activity preceding the shock. Symptoms, the number of shocks delivered, and how you feel after the shock. The physician may wish to be notified each time the device discharges.
Okay, so give me one sentence. If the ICD fires, what will you do? That's a lot of teaching there, but basically, what do they want you to do? If it fires, what should you do?
Record.
Record
That's it.
The diary.
time and yeah.
That's it. I said, give me one statement.
Yeah, you said.
Just record. Yeah.
What do we tell the patient to do? If it fires, do what? Because remember, why did it fire? Why did it?
They had a dysrhythmia, so I guess call their physician.
That's the answer. Fire. Yes, of course you'll write down, etc. You put in your diary, but more importantly, what do you do about what you just wrote down?
You report to physician.
Call the doctor about it, because of course, are we happy that you have a dysrhythmia? Happy?
Yes.
Yeah.
Of course not, right? That's dangerous. They're lucky they had an ACD, but of course, the doctor needs to know that. That way, we can make adjustments. Maybe the doctor wants to come in, for exam. Okay, so let's see. So how are your medications working? Why did this occur? Right? Very important to tell them what to do. And of course, with the CPR, who should learn CPR? The patient?
Family members, caregivers.
Nurse and the
Right, because you can't do CPR on yourself, right? Should be the family member. And that should be it. Yeah. We have temporary ones, like here, until you can get an ICD in. Although some patients, especially if the doctor, there's some contraindication. Let's say you have an active infection, we can't put in an ICD yet because we have to wait until we treat the infection before we put a permanent ICD. There's a life vest. Okay, this is literally a vest that you wear. Of course, you'll have to wear this on your skin, meaning no shirt underneath, and you can wear a shirt over it. Because there are electrodes, okay, that will detect your dysrhythmia, and then it will deliver a shock. So it's bigger than ICD, but it's it works. It's like a life jacket. And that's it. Any questions on